Okay, now let us start with chapter 65 of your Apurba Sastry Essentials of Microbiology, which is about infections due to non-fermenting gram-negative bacilli, which are in this chapter we'll be previewing Pseudomonas infections, Burkholderia infections, Acinetobacter infections, Streptomonas infections, and Elizabeth Kingia infections as well. So to start with, non-fermenting gram-negative bacilli NFG&B do not ferment any sugars, but they utilize the sugars oxidatively. Most of the NFG&B exist as environmental commensals in hospitals and inhabit in moist environments, detergents, and IV fluids. They are resistant to multiple antibiotics, however, they cause various infections in the hospitalized patients, of which respiratory infections are noteworthy. Examples include Pseudomonas aeruginosa, Burkholderia cepacia, Acinetobacter baumannii, Stenotrophomonas maltophilia, and Elizabeth Kingia meningosepticum. However, there are some of the non-fermenters which are principally community-associated pathogens. Classical example is Burkholderia pseudomyli, which causes infection of various systems, of which the notable are respiratory, skin and soft tissue, and bloodstream infections. So now start with Pseudomonas infection. Pseudomonas is an oxidase positive pigment producing non-fermenting gram-negative bacilli. It is a major pathogen responsible for most of the hospital acquired infections and also of importance in patients with cystic fibrosis. Virulence factors and pathogenesis. The pathogenesis of Pseudomonas is greatly attributed to its ability to develop widespread resistance to multiple antibiotics and disinfectants, and also by producing a number of virulence factors. Colonization. The first event to initiate the infection is to adhere and colonize the host defense. Various factors help in adhesion, such as pili or fimbri, the organ of attachment, and polar flagellum, mediates chemotactic motility to reach the host surface. Second comes the toxin mediated immune evasion and tissue injury. Pseudomonas aeruginosa produces probably the largest number of toxins and enzymes among the gram negative bacteria. These can be grouped into non-diffusible toxins and diffusible toxins. Non-diffusible toxins, example exotoxin S, U, T, and Y. Colonized Pseudomonas injects these toxins into the host cells, which allow the bacteria to evade the phagocytic cells and induce tissue injury by their cytotoxic activity. Diffusible toxins, for example, exotoxin A, proteases, phospholipases, hemolysins, elastases, procyanin, etc., can act freely and mediate tissue injury. Exotoxin A. This is the most important virulence factor of Pseudomonas aeruginosa. It inhibits protein synthesis by inhibiting elongation factor 2. Mechanism of action is similar to the diphtheria toxin. Host inflammatory response. Host elicits an inflammatory response as a defense mechanism against various components of the bacilli, such as endotoxin and flagellin, mediated through the Tor-like receptors. However, florid and stronger inflammatory responses can lead to tissue injury and septic shock. Pigment production. Pseudomonas produces a number of pigments which diffuse freely into the surroundings, inhibit other bacteria, and mediate tissue injury. Biocyanin. It is a blue-green pigment produced only by Pseudomonas aeruginosa. Fluoroserine or pyoviridin. It gives greenish-yellow color to the colony produced by most of the species. Pyrumin imparts red color and biomelanin imparts brown-black color. Alginate coat. Mucoid strains of Pseudomonas have a slime layer or alginate layer which facilitates biofilm formation, thus helps in adhesion to host cell and purulent mucus. Such strains can cause infections in patients with cystic fibrosis. Capsule. Many strains of Pseudomonas possess polysaccharide capsule which prevents the bacteria from phagocytosis. Now coming on to the multi-drug resistance of Pseudomonas. Pseudomonas is known to possess genes coding for resistance to several antimicrobial agents, thereby helping the bacilli to survive under antibiotic pressure, especially in the hospital environment. Biofilm formation is another mechanism by which it prevents the entry of antibiotics into the bacterial cell. Multi-disinfectant resistance. It helps the bacilli to grow in presence of various disinfectants, thus spreading the infection in the hospitals. Wide temperature range. Pseudomonas survives in extremes of temperatures 5 to 45 degrees Celsius, which allows the bacilli to be ubiquitous. Now the clinical manifestations. Pseudomonas aeruginosa is notorious to cause infections at almost all sites, most common being lungs, skin, and soft tissues. Most of the infections are encountered in hospitalized patients who get colonized with the organism either from the heavily contaminated hospital environment or from the hospital staff through contaminated hands. Colonized patients develop the disease in the presence of underlying risk factors such as burn wounds, patients with immunosuppression, and post surgeries. The manifestations are as follows: healthcare associated infections such as ventilator associated pneumonia VAP, central line associated bloodstream infection CLABSI, catheter associated urinary tract infection COTI, and surgical site infection SSI. Chronic respiratory tract infection, it occurs in patients with underlying conditions that cause airway damage such as cystic fibrosis or bronchiectasis. These infections are usually caused by mucoid strains of Pseudomonas. Bacteremia leading to sepsis and septic shock, infective endocarditis, native valves, it occurs among IV drug abusers. Ear infection, the infections are either mild, such as tremors ear among children, or serious, necrotizing, from designated as malignant otitis externa in elderly diabetic patients. Eye infections such as corneal ulcers in contact lens wearers and endophthalmitis secondary to bacteremia. And Shanghai fever is a mild febrile illness resembling typhoid fever. Skin and soft tissue infections such as burn wound infection, ecthyma gangrenosum, green nail syndrome, and cellulitis with blue-green pus also can be caused by Pseudomonas. Other infections include bone and joint infections such as osteomyelitis and septic arthritis, and also meningitis in post-operative or post-traumatic patients. Now coming on to the lab diagnosis. The sample collection: pus, wound swab, urine, etc. The direct smear: gram-negative bacilli and pus cells. Culture: nutrient agar gives opaque irregular colonies with metallic sheen, iridescence, and blue-green diffusible pigments. Blood agar produces beta hemolytic grey moist colonies. On McConkey agar, it produces NLF non-lactose fermenting colonies, and selective media is cetrimide agar. Culture and smear motility: motile gram-negative bacilli are seen. For identification: catalase positive and oxidase positive organism. ICUT test: indole negative, citrate positive, urease negative, and triple sugar iron tests, gas negative, and H2S is also absent. Automated infections such as Maori Toph or Vitek and antimicrobial susceptibility testing can also be done. Now coming on to lab diagnosis. Specimen: various specimens such as pus, wound swab, urine, sputum, blood, or CSF are collected depending upon the site infected. Direct smear: gram staining of the specimen shows plenty of pus cells and slender gram-negative bacilli and occasionally capsulated. Culture: Pseudomonas is non-fastidious, can grow in ordinary media. It is an obligate aerobe, hence specimen after being inoculated onto various media should be incubated aerobically at 37 degrees Celsius for 24 hours. Peptone water: Pseudomonas forms uniform turbidity with a surface pellicle formation due to more oxygen tension at surfaces. Nutrient agar produces large opaque irregular colonies with a metallic sheen described as iridescence. Pigments: most strains produce diffusible pigments which are either blue-green polycyanin or yellow-green pyoviridin, pyocyanin and pyoviridin. Some strains are non-pigmented. Mostly colonies of Pseudomonas have a characteristic sweet ether or alcohol-like fruity odor. Blood agar produces beta hemolytic grey moist colonies on blood agar. McConkey agar produces pale non-lactose fermenting colonies, and on selective media such as cetrimide agar, it can be used to isolate the organism from mixed growth in purulent specimen. Now the culture smear and motility. Culture smear shows gram-negative bacilli. They are actively motile with single polar flagellum. By hanging drop test, it can be seen. In this figure, we can see the Pseudomonas aeruginosa colonies. Nutrient agar with large irregular colonies with metallic sheen and green color pigmentation are characteristic of Pseudomonas aeruginosa colonies. Alright, now coming on to the identification. Identification of Pseudomonas from colonies is made either by automated identification systems such as Marlitov or Vitek, or by conventional biochemical test as described below. Oxidase and catalase positive non-fermenters do not ferment any sugar but utilize sugars oxidatively. ICUT test: indole test negative, citrate test positive, urease test negative, and triple sugar iron test shows alkaline or slant or alkaline but no change with no gas and no H2S. Now coming on to antimicrobial susceptibility testing. AST is essential to administer appropriate antibiotics. It is performed by disc diffusion method on Muller-Hinton agar or by automated MIC detection method by microbrod dilution, example Vitek. Typing methods. Pseudomonas aeruginosa is an important cause of healthcare associated infection. It is essential to type the isolates beyond the species level to find out the relatedness between the isolates. This is useful during outbreaks to trace the source of infection. For epidemiological studies, various typing methods are used such as bacteriocin, biocin typing, antibiogram typing, serotyping, molecular typing methods such as pulse field gel electrophoresis, and sequence based typing method. Now coming on to the treatment part of Pseudomonas infection, Pseudomonas species exhibit high degree of resistance to most of the antibiotics. Only limited antimicrobial agents have anti-pseudomonal action such as penicillins, piperacillin, mesoxylin, and ticaracillin, cephalosporin, ceftazidime, cefoperazone, ceftolozane, and cefepime. Beta-lactam or beta-lactamase inhibitors combination like piperacillin, tazobactam, and cefoperazone, sulbactam are given. Carbapenem, imipenem, meropenem, and doripenem are given. For monobactam, only one azithromycin is there. Aminoglycoside, tobramycin, gentamicin, amikacin can be given. In quinolones, ciprofloxacin, levofloxacin can be given, and for polymyxins, polymyxin B, colistin in nebulized form or for pneumonia is given. Note: Pseudomonas aeruginosa is intrinsically resistant to ceftriaxone, amoxicillin clavulinate, ampicillin sublactam, atrapenem, tetracycline, tigecycline, cotrimoxazole, and chloramphenicol. Therefore, these drugs should not be used in the therapy. Now, drug resistance. Pseudomonas possesses a number of drug-resistant plasmids which confer resistance to several antibiotics. Many strains are producers of beta-lactamases such as ESBL, extended spectrum beta-lactamases, carbapenemases, example New Delhi metallo-beta-lactamase NDM, and AMP-C beta-lactamases. Lastly, the preventive measure, infection control measures, contact precaution such as hand hygiene are crucial to limit the spread of infection. Okay, now starting with the Burkholderia infections. The Burkholderia species are also oxidase positive non-fermenters similar to Pseudomonas. However, they differ from the latter in being bipolar stained, safety pin appearance, and resistant to polymyxin B. Melioidosis, Burkholderia pseudomallei. Burkholderia pseudomallei is the causative agent of melioidosis. Habitat: Burkholderia pseudomallei is a saprophyte of soil and water and have large number of animal reservoirs. Melioidosis also occurs in rats, rabbits, and guinea pigs. Mode of transmission: human and animals are infected by various routes such as inoculation, inhalation, aspiration, or ingestion. Man-to-man transmission is very rare. Virulence factors: Burkholderia pseudomallei is perhaps the most virulent among the non-fermenters. Several virulence factors are described such as polysaccharide capsule, lipopolysaccharide, toxin, enzyme, and protein such as hemolysin, lipases, and proteases. Now the risk factors. Melioidosis occurs mostly when underlying risk factors coexist such as diabetes, renal failure in adults, and traumatic inoculation in children, weather, rainy season, and occupation like rice farmers. Incubation period may range from 2 days to many years. Some cases may have long latency, presented long time after the exposure. Hence, melioidosis is also known as the Vietnam time bomb disease. Clinical feature: melioidosis can present with array of manifestation, hence called as great mimicker. Grouped into 4 types of clinical presentation: acute localized infection, present as localized nodule, fever, general muscle ache, and many progress rapidly to infect the bloodstream. Subacute pulmonary infection ranges from mild bronchitis to severe tuberculosis like pneumonia with cellulitis and lymphangitis. Acute bloodstream infection seen in patients with underlying illness such as HIV, renal failure, and diabetes, and present as septicemia, septic shock with metastatic pus-filled skin lesions and disorientation. Chronic suppurative infection forming abscesses involve various organs such as joints, viscera, lymph node, skin, brain, liver, lung, bones, and spleen. Bioterrorism. Burkholderia pseudomallei can be used as a potential agent for biological warfare. Geographical distribution: it is estimated that around 1.65 lakh new cases of melioidosis occur worldwide every year with mortality as high as 50%. World: melioidosis has been endemic in Thailand, Australia, Singapore, India, Indian subcontinent, and other Southeast Asian countries. India. Melioidosis has been reported mainly from South India such as Tamil Nadu, Karnataka, Puducherry, and Kerala. Lab diagnosis: depending on the site of infection and various specimens are collected such as sputum, purulent discharge from the lesion, aspirated pus, etc. Direct microscopy: they are gram-negative bacilli that typically exhibit a bipolar or safety pin appearance, which is better appreciated when stained with methylene blue. Culture: Burkholderia pseudomallei is an obligate aerob, grows on various media, example nutrient agar, blood agar, and McConkey agar. Colonies are typically rough and corrugated, similar to colonies of Pseudomonas tuzeri. Ashdown medium is used as selective medium where it produces wrinkled purple colonies. Identification species identification is made by conventional biochemical test, example resistance to polymyxin B, or by automated method such as Vitek. Malditov is not yet validated for identifying Burkholderia pseudomyeli. Latex agglutination test with specific antisera can be used to identify them from the cultures. Treatment. Treatment of melioidosis involves intensive phase 2 weeks ceftazidime or carbapenem is given, followed by maintenance phase 12 weeks oral cotrimoxazole is given to eradicate the bacilli and to prevent relapse. Doxycycline or amoxicillin clavulinate are the alternatives. Burkholderia pseudomonas is intrinsically resistant to many antibiotics, including penicillin, first and second generation cephalosporin, macrolide, rifamycins, colistin, and aminoglycosides. Post-exposure prophylaxis. After exposure, particularly following a lab accident, combined treatment of cotrimoxazole with doxycycline is recommended. Note: Burkholderia pseudomyeli are intrinsically resistant to penicillin, atrapenem, polymyxin, and fosfomycin. Therefore, these drugs should not be used in the therapy. Now, the Burkholderia malaria infections. Before discussing that, let us see the images. In figure A, we see the gram stain smear showing gram-negative bacilli with safety pin or bipolar appearance of Burkholderia pseudomyeli. In figure B, we see the rough and corrugated colonies on McConkey agar, and in C are shown wrinkled purple colonies on Ashdown's medium. Now, Burkholderia malaria infections. B. malaria is a pathogen of horses where it causes glanders, nasal discharge and ulcers in the nasal septum and farsi, skin lesion and lymph node involvement. Transmission. Unlike other species, B. malaria is not an environmental organism. It is strictly zoonotic, transmitted from horses to man either by direct inoculation or inhalation. Okay, human infection is characterized by local skin nodules and lymphadenitis if transmitted by inoculation, pneumonia, ulceration of trachea and sepsis if transmitted by inhalation. Lab diagnosis. It is similar to that of Burkholderia pseudomyeli. However, B. malaria differs from B. pseudomyeli in being non-motile and oxidase negative. Treatment is same as that of B. pseudomyeli. Burkholderia Sepicia complex infections. B. Sepicia complex comprises of 18 closely related genomic species and currently is the most commonly encountered Burkholderia species. It is an environmental organism that inhabits most moist environments, detergents and IV fluids. It has been recognized as plant pathogen causing onion rot, sepia, Latin for onion. Virulence factor possesses multiple virulence factors such as cable pilus, a type of fimbriae which is capable of binding to lung mucus, elastase. LPS of B. cepacia is among the most potent of all bacteria, stimulates inflammatory response in the lungs. Various clinical manifestations include cepacia syndrome. It is characterized by rapidly fatal respiratory infection and septicemia in patients with cystic fibrosis. Nosocomial pathogen. It is resistant to multiple antibiotics, hence has been emerging as an important nosocomial pathogen in ICUs, causing pneumonia, wound infection, etc. Lab diagnosis. Clinical and environmental specimen can be inoculated on selective media. Optimum growth occurs at 30 degrees Celsius. Biochemical reactions on or automated methods such as Malditov or Vitek can be carried out to differentiate the genome of species. Prevention. Implementation of infection control measures is crucial to prevent nosocomial spread of infection. Now, the treatment of Burkholderia cepacia infections. Burkholderia cepacia is intrinsically resistant to ampicillin, ampicillin sublactam, amoxicillin clavulinate, ertapenem, polymyxin, and fosfomycin. Therefore, these drugs should not be used in the regime. The effective drugs are cotrimoxazole, meropenem, doxycycline are the most effective, followed by levofloxacin, ceftazidime, avibactam, ceftolozane, tazobactam are the alternatives. Now, Acinetobacter infections. Acinetobacter are the saprophytic bacilli present in the environment, soil, water, and phytosphere. However, during the last 2 decades, it has gained increasing attention as a nosocomial pathogen. Genome of species. DNA hybridization studies have shown that Acinetobacter can be grouped into several genome of species. A. baumannii is the most pathogenic species. Most other species such as A. caloaxitius and A. lophi are rarely pathogenic to man. Sources: hospital environment is heavily contaminated with these organisms. They are commensals in skin, oral cavity, and intestine. The carriage rate is much higher in the healthcare setting than community. Promote colonization. Unhygienic practices in hospitals, contaminated hands of staff, and warm hospital environment summer promote colonization. Patients with underlying diseases or immunosuppression are predisposed to invasion and pathogenesis. Pathogenesis is not fully understood, while the multi-drug resistance is because of the ability to develop drug resistance rapidly to almost all available antibiotics and makes it dangerous in hospital settings. Various virulence factors are also attributed to the pathogenesis, such as outer membrane protein OMP-A. It mediates adhesion, invasion, and cytotoxicity through mitochondrial damage. Lipopolysaccharide induces inflammatory response that leads to tissue injury, and its ability to form a biofilm also accounts for the pathogenesis. Now, the clinical manifestation: A. Baumani causes widespread hospital infections such as ventilator associated pneumonia, central line associated bloodstream infections, post neurosurgical meningitis, catheter associated UTI, wound and soft tissue infections, infections in burn patients. In epidemiology, several hospital outbreaks due to Acinetobacter have been reported throughout the world. Lab diagnosis is then obligate and AROP glows well on ordinary medium. Specimen can be inoculated on blood agar, non-hemolytic colonies, and McConkey agar, lactose non-fermenting colonies with faint pink tint. Important identification features are gram staining are gram negative cocobacilli, oxidase negative and catalase positive, non fermenters of sugar and non motile, ICUT test, indole test negative, citrate test positive, urease test negative, and TSI triple sugar iron test shows alkaline slant or alkaline but with no gas and no H2S. Species identification can also be made by automated identification systems such as Malditov or Vitek. In this figure, we can see the lactose non-fermenting colonies with faint pink tint of Acinetobacter on McConkey agar. Antimicrobial susceptibility testing is performed by disk diffusion method on Muller-Hinton agar or by automated MIC detection method by microbrod dilution, example Vitek. Prevention: infection control measures such as improved hand hygiene are essential to prevent nosocomial infections due to Acinetobacter. Treatment: Acinetobacter infections. Acinetobacter is notorious to develop resistance to multiple drugs, including beta-lactams, aminoglycosides, and quinolones. Beta-lactam resistance can be attributed to the production of beta-lactamases such as metallo-beta-lactamases (MBL), AMP-C beta-lactamases, and OXA-type beta-lactamases. Choice of antibiotics should always be guided by susceptibility reports. Most of the hospital acquired isolates are resistant to carbapenems. Common antibiotics indicated are beta-lactam or beta-lactamase inhibitor combination like piperacillin, tazobactam, or digacycline and colistin. Note: Acinetobacter is intrinsically resistant to ampicillin, amoxicillin, clavulinate, etrapenem, azithromycin, chloramphenicol, and fosfomycin. Therefore, these drugs should not be used in the therapy. Now, the Stenotrophomonas infection. S. maltophilia is a saprophyte found in the rhizosphere soil surrounding the plant roots. Colonization: the organism is acquired from the environment which is favored by immunocompromised conditions and patients on broad spectrum antibiotics. Clinical manifestation: S. maltophilia can cause various hospital infections such as pneumonia in ventilated patients, bloodstream infections, and ecthyma gangrenosum in neutropenic patients. Lab diagnosis: identification of S. maltophilia is made either by conventional biochemical test or by automated identification systems such as Malditov or Vitek. Treatment of Stenotrophomonas infection: it is intrinsically resistant to most antibiotics such as most of the beta-lactam, including carbapenem, polymyxin, aminoglycosides, and fosfomycin. The recommended antibiotics are cotramoxazole, minocycline, and levofloxacin. Now, the Elizabeth Kingia infections. E. meningosepticum is the main species, formerly placed under the genus Chrysobacterium or Flavobacterium. Manifestation: it is saprophyte in soil, water, and hospital environment. However, it can cause nosocomial infection in patients with underlying immunosuppression such as neonatal meningitis, pneumonia, sepsis, endocarditis, bacteremia, and soft tissue infections. Lab diagnosis: it is a non-motile gram-negative bacilli. Identification of E. meningosepticum is made by either conventional biochemical test or by automated identification system such as Malditov or Vitek. Treatment, it is susceptible to fluoroquinolones and cotrimoxazole. However, beta-lactam should be given with caution as it produces beta-lactamases. Now, Elizabeth Kingia Anopheles is another species which has recently emerged as a nosocomial pathogen causing sepsis, especially in the neonatal units. Okay, so this completes the chapter. Let's discuss some questions. Write a short note on valence factor, Pseudomonas aeruginosa, melioidosis, and medically important non-fermenters we can write. Now the MCQs, ecthyma gangrenosum is caused by Pseudomonas. Drug used in Pseudomonas treatment is ceftazidime. And which of the following is not active against Stenotrophomonas maltophilia? So cotrimoxazole is active, colistin is given, levofloxacin is also given, but meropenem is not given. Okay, so this completes our chapter. Next, we'll be starting with myxovirus infections. Okay, so meanwhile, like to subscribe. Thanks for watching.